So just to get back to this, so the 4Ms, we talked about medication and the importance of identifying unsafe medications. As an example, we know that opioid pain medicines can increase falls in older adults. And I had one patient once who took tramadol one time at bedtime. And I gave some feedback to her, just explaining that that medication probably was contributing to some of her fuzziness in thinking and could actually lead to dementia over the long run. And so she turned to me, she says, well, maybe I don't need that pill at night after all. So that was an opportunity for what we call deprescribing. In terms of looking at the mind or mentation, is that we want to regularly try to identify moments in an older adult's life of either depression, anxiety, memory loss, or what we call loss of executive function. And then in terms of mobility, the big emphasis there is to try to avoid falls. So for those of us who live in North and South Dakota, it turns out that our fall rates are fairly high, and that more importantly, the injury related to those falls are amongst the we're amongst the top 4 states in the country for injuries related to falls. So that's just really important to note, and to have a understanding and a commitment to trying to reduce both falls and falls with injury. Okay, so if you don't mind, what I'd like to do is just talk about what matters. Yeah, so we're talking about, actually, can you go to my first slide? Next one, there's one more slide up there. Yeah, so this is what matters, and I just wanted to bring attention to this particular slide deck where Jean Miro, there's a little piece of his, one of his paintings. And so we're trying to, again, with our program at the University of North Dakota, is try to connect imagery with important concepts. And we're hoping that somehow creates a more fuller understanding of some of these principles that we're trying to convey around these geriatric 4Ms. Next slide, please. So the goals of this particular presentation is to look at what matters as a driver for patient-centric healthcare. Also want to look at what some of the barriers are, both from a provider's point of view and from a older adult's point of view. And then look at different strategies to have ongoing information gathering about what matters. It's just not as they say in hockey, it's not a one-timer. We have to do this multiple times. Next slide, please. Yeah, so here you have a left and a right situation where the individual on the left is very highly functional, very engaged, and for him, feeling strong and well enough to care for an active young grandchild or grandchildren may be the most important thing that matters to him. It kind of reminds me of an episode I had with my then 4-year-old grandson, who is chasing me around, and his father reflected. He says, "You're pretty fast for an old guy." And so my grandson had no clue. He thought he was just playing with somebody else. But again, being highly functional is an important thing in my thinking, and so for that reason, I try to do as much exercise as I can. Conversely, on the right side, we have somebody that may have entered into a stage of what we call frailty. So this is an individual that is more sedentary, or maybe has some cognitive impairment. And so with pain, they may be on heavy medications. And so maybe for that individual, what matters is not so much taking care of grandchildren, but rather looking at being able to just carry on a conversation without a slurred speech from the medications or something similarly. Okay, next slide, please. Yeah, and then again, how invested are people? So, I see patients that are highly invested. They give me a list of their glucoses, every hour on the hour, each day. They'll take their blood pressures, 5 or 6 times a day. And all to be encouraged. I don't like to discourage people from what we call an overkill. But again, that's one extreme, as opposed to the laissez-faire approach where somebody might, again, be more sedentary. They, plus minus if their glucose levels are up or down, they just don't like checking them that much. And, yeah, they get a blood pressure cuff, but they don't use it so much. Now, it may be aspirational, for providers and family members to encourage them to be a little bit more engaged with self-management. And that's a different issue. But again, just to point out that what matters to individuals, that baseline understanding and belief system may have a large range that we need to understand and respect. Next slide, please. So very interesting comment about Dr. Gawande, who says the waning days of our lives are given over to treatments that addle our brains and sap our bodies for just a sliver's chance of benefit. They're spent in institutions, nursing homes, intensive care units, where regimented, anonymous routines cut us off from all the things that matter to us in life. And so I think this is an important comment. If you have not read the book On Being Mortal, it's really a nice reflection of how we've come to understand the latter part of our lives and how we transition into things that really, just the fact that 80% of all healthcare costs are spent on the final year of life in the United States, I think is a statement in of itself. Next slide, please. So I think it's important for us as both from family members and providers to know and communicate what priorities are to older adults. So sometimes it takes a little bit of reflection. So the older adult maybe needs to have some homework and say, ask them, what are the important things for you? And then once you decide what those important things are, to communicate those ideas to your loved ones, as well as to your provider. And then by doing this, it will help promote what we call shared decision-making. And I'll just give you an example. I had a patient come in one time who I just didn't look like, she had much spirit or oomph. And I asked her, I said, it seems like you're really done. And she says, yeah, she says, I'm okay. I really feel like I'm towards the end of my time here. I don't want to be hospitalized. And I said, that's fine. So, we treated her conservatively, tried to relieve her pain, and had her go home. But then the daughter comes back from work and finds her mother in this kind of debilitated state. Really, I think the patient was probably dying from an underlying infection that she didn't want to be treated for. Daughter whisks her off over to the hospital. Hospital says, oh my gosh, she's in kidney failure. Let's put her on dialysis and let's do that. Send her to the intensive care. And remarkably, she survived. I saw her in clinic and I said, what happened? She says, oh, my daughter didn't listen to me. And so, it's a good example of where sometimes we might do more harm by intervening than if we let nature take its own course. So that's just a very vivid example that remains with me to this day. Next slide, please. So in defining what matters, we can see in this figure here all the jiggly ropes or squigglies going through a filtering process that creates some alignment here. And so it's important that not only do we understand what the older adult specific healthcare goals are and their preferences, but also to try to align those with what we're trying to do. So this is an important consideration of understanding each older adult specific healthcare outcome goals, and sometimes recognizing that their healthcare goals may not be so realistic. I had an individual in a long-term care facility who was blind, and I asked him what his healthcare goals were, and he says to see again. And so, in a more metaphoric sense, we were talking about what he might be able to see, but the actual physical reversal of his blindness was medically impossible. So again, trying to meet the patient's goals with what's pragmatic and practical sometimes are a challenge. But we need to again recognize what the thinking is in the person's mind, and no matter what stage they are in. So even for people that have cognitive impairment, to express preferences is just so important to maintaining that level of autonomy that we would like to have for all people. Next slide, please. So in defining the health outcome goals, we want to understand what the values are of the individual, look at their activities. So for some people, creativity is so important. So maintaining those hobbies. For others, I mean, you look at Dr. Anthony Fauci, 80 years old, and he's still, occupied, he still has an occupation, right? He's still working. Some people just don't want to retire. So again, understanding what those goals are. It may include things like spirituality, the importance of family, staying physically active. I think they talk about the baby boomers as not accepting physical inactivity, that they want to be out moving around. That's very important as a generational concept. Next slide, please. So not only do you have healthcare goals, but you have care preferences. This is a picture here of somebody that's on 3, 6, 8 pills. Okay, so this individual has 100% chance of having a medication to medication interaction. And more than likely, this person is going to go back to the doctor with some side effects. And the doctor is going to say, well, let me give you your 9th medication to help treat the symptoms of your loose bowels, for example. And so now they've given them an anticholinergic medication that can cause more brain fuzziness. And so it goes. It's like a dog chasing its tail with this over medication. But recognizing that there are some individuals who have different opinions about self-management tasks, whether they want to go to the doctor or not, as well as screening tests. So one of the issues that comes up is that if a doctor asks you to do a certain test, it might be important to ask, well, why do I need this test, and what are we going to do if there's something wrong with it? So, for example, in cancer screening, I said, do you want a mammography? And if the individual says, no, I would never have surgery anyways, well, that kind of answers the issue of whether you want to do that screening test or not. So that might serve as a good example. Next slide, please. So let's talk a little bit about what the impediments are. So here on the left, you have an older doctor that I can relate to, who's probably stuck in his ways and may not really want to think about what matters to the older adult, because they're there to solve problems and not to, think about what the patient may want. I'm the doctor, kind of concept. And then on the right side, somebody who already ends up in the hospital and hadn't really thought about what their future might be and what their healthcare preferences are. So what are those impediments? Next slide, please. So some of the rabbit holes, where we go down, and that can be a pitfall for the older adult, is a rapid change in health status. I mean, how much have we seen with the COVID pandemic that unexpectedly somebody gets ill, severely ill, and they really have not had time to reflect on what their preferences are, and really don't have much of a choice at that moment because it's such an emergency. In terms of the other impediment, it could be more insidious or chronic changes such as Alzheimer's disease or small multiple strokes that might be causing some impairments, so that you really are then at some point unable to reflect and express your wishes. Next slide, please. There might be ambivalence. People just don't think about, well, why should I care about my advanced directives? Things will take care of themselves. There might also be mood disorders. You might have situations where somebody is anxious or maybe low mood, depressed. We talked about grief, unresolved grief. All these factors can play a role into defining what matters, to that particular individual. Next, yeah. The other thing that I find interesting is that not everybody really has a full appreciation of remaining life expectancy. I think we all kind of move on with this idea that, well, we just keep moving on and don't really reflect like, oh, maybe I've got 5 to 6 years of remaining life expectancy. And of course, I'm speaking from a geriatrician's point of view. And there's a whole discussion about how to try to change your trajectory from, a longer and more well-lived life. But there is this issue of lack of recognition as to how many years we do have remaining to live. The other part is you just may not want to talk about end-of-life issues because it may just bring the whole issue either as a spirit or you bring the issue up, and of course it's gonna nip you or bite you. So avoidance is another reason for not talking about what matters. Next slide, please. So some of the knowledge gaps that exist, and I think if you're family member, healthcare provider, there's two concepts here of absolute life expectancy. So that's the day that you're going to be buried, and then there's what we call active life expectancy, and that's a 2 to 3 year period before somebody passes on, whereby there's a decline in their functional ability. And so no matter what age somebody passes away, they will more than likely experience a 2 to 3 year pre-death period of some form of functional disability. It could be cognitive, it could be physical, it could be emotional, or all three. But there is this very steady 2 year to 3 year window that precedes death. And I think we often don't recognize that. The other issue is that both providers and family members often overestimate their life expectancy by anywhere from 5 to 10 years. And that in itself, it gives hope, and we don't want to take hope away, but also just, being realistic about that window, as we say with the medicine wheel there, with the white wedge or pie representing north, and the latter phase of life. Next slide, please. Yeah, so here's a study from a while back that surveyed individuals with end-stage heart failure. And you can see the top arrow there is that individuals, when asked with end-stage heart failure how much longer they had to live, and they would all say, well, another 10 to 12 years. But in reality, the epidemiologic data shows that they probably have less than 5 years of remaining life expectancy. So again, individuals, the older adults' perception is twice that of what reality might actually suggest. Next slide, please. So the providers themselves, the physicians, nurse practitioners, and healthcare workers may also have some pitfalls with understanding what matters. In some instances, like the example I gave you, they'll accept family over patient wishes. And a lot of times there's this family tension, do everything, where the patient says, not so fast. And so you always have these tensions between family members and whether the doctors accept them. And then also, just as represented in this picture here, is that a lot of our medicine is based upon emergency care. And boy, if you show up in the emergency room, it's full code until somebody says otherwise, and you almost have to take the physician's hand away from the those EKG paddles, for resuscitation, because somebody, you're there for an emergency room, purpose. And so they're presuming that you're there for life-sustaining treatment. Next slide, please. Probably the biggest thing is that providers just don't ask. And again, that gets back to the earlier question. When was the last time you went to a physician or nurse practitioner visit and were asked what matters to you? It's just not in our usual routine as medical providers. And so in part, sessions like these, we're trying to educate providers and family members to really start to communicate with each other on the importance of defining what matters. Physicians may not look at advanced care plans. And so when I see a patient in our electronic medical record, in the upper left-hand corner, it states whether they have an advanced care plan or not. As I mentioned in the chat box, 50% of patients that we see in our clinic in Fargo at Sanford don't have any advanced care plans documented whatsoever. And then finally, the physicians and other providers may end up overestimating lifespan of their individuals and just coming to an understanding as to what that prognosis is. It is an important concept that we need to consider, with each encounter that we have between providers and the older adult. Next slide, please. Yeah, so this just reemphasizes, this is data that I collected from my own clinic. Basically, a little over half of the individuals did not have any documented advanced care plan. So that's a real goal for us to try to improve what matters amongst our older adult population. Next slide, please. So the other part is that medical complexity. How many chronic conditions you have can really put a twist onto defining what matters. And this is a very dynamic situation here. So you can see on the left graph there that as people have more and more chronic conditions, on the bottom part of the axis here, look at half of the people there in that one column. Half the people have some physical limitations if they have 5 or more chronic conditions. And then with the next graph, you can see social limitations increase with more chronic conditions. People become more withdrawn, more isolated, as we heard earlier in the presentations. And then interestingly, 1 out of 4 individuals with 5 or more chronic conditions have some form of cognitive impairment. And I think that's important to recognize. And like I say, a lot of times as providers, we don't fully appreciate the cognitive limitations that occur with multiple chronic conditions. So again, these are issues that impact defining what matters to the older adult. So next slide, please. Oh, the other thing that really impacts what matters are all the medical subspecialists that we see. So here we have cases of seeing the neurologist in the right upper corner there, maybe a cardiologist, and then down in the left corner, you see an orthopedic surgeon, and then to the right lower corner, you see a rheumatologist. And good gracious, you see all these specialists. I actually did a survey in my clinic and found that there were more specialty visits per patient than there were primary care, and it was about a 2-to-1 ratio. So there was about a 6 to 8 specialty visits compared to 2 to 3 primary care visits. And so that in itself shows you, how the healthcare system is lopsided towards specialty care that doesn't really care what matters, quite honestly. A very jaded view is to say that providers, with specialty care would like to do their specialty. And so that's their focus. They don't look at the broader view of what matters and how that might impact the older adult's life. Next slide, please. Well, I have a picture here of Leonard Nimoy. I happen to be a Star Trek fan, and this is his signal. This is what he was, the Vulcan sign language was live long and prosper. I like the picture because it represents some interesting things from a physical diagnosis point of view. Firstly, if you look at the picture of Leonard Nimoy, he's got temporal wasting, so he probably had protein calorie malnutrition when this picture was taken. And you can also see on his hand the loss of muscle mass. And so just by observation, you can see that this individual in his later years of life really became quite frail. And so that's to my first point here, is trying to understand what the functional trajectory of older adults might be. And it's important for the provider to get a sense of where they are functioning. Are they having problems with activities of daily living, or are they having problems with instrumental activities of daily living? I think it's also important to estimate life expectancy. And so again, going to this picture of the actor Leonard Nimoy, if you look at his face, does this person look more like a 60-year-old, or this person look more like an 80-year-old? And I think if you give that kind of first glance impression, you'll get a better appreciation for what their life expectancy might be. There also are tools that we can use for estimating life expectancy. And the older we get, so as an 85-year-old, the likelihood is that they're going to live to 91 to 92 is pretty strong. And if somebody lives to be 94, the chances of their making it to 98 to 100 is pretty strong. So once you get past the average life expectancy, you've got an even better chance of living what we call amongst the oldest old. So that's an important consideration. Also, I want to point out that the mission de la vida, it's important to identify what people's missions are, if any. And if you ask them, what do you do when you wake up in the morning? And if they say they take a shower and have breakfast, and that's it, you've got an issue to deal with in terms of defining what their mission is. Next slide, please. So I just want to bring your attention to the bottom part of this slide, is that there is a pragmatic element in defining healthcare preferences. That's actually what the patient can do. And then the more aspirational on the right side, which is what the patient wants. And so the idea is trying to align what their preferences are and their abilities to what might be more aspirational goals. So that's why, for example, I'll snitch the cell phone from a patient and look at their, with permission, look at that little heart emblem, an application that says how many steps they take each day. And I said, oh, it says here that you're taking 2,000 steps a day. How about if we increase it to 2,500 steps a day? So that's a moment of aspirational interventions, if you will, for increasing mobility, which is one of the 4 M's, right? Okay, next slide, please. Let's skip this one. This one's a little busy. So I think it's important for the providers to firstly check the electronic medical record or their medical records to see if there are advanced directives documented. And then also importantly, to ask about the 4 M's. So these questions about what matters can be as simple as, do you have family in the area to help you if needed, right? So that was one of the questions that came up in one of the earlier presentations. Who's your go-to person? Another way to find out what matters is describe a typical day. What do you do during the day? And that will help define some of the 4 M's, because if somebody says, I take medication 3 times a day, now you have an opportunity to see, well, what if we got your medications down to once a day? Would that make a difference in your life? And then what do you like to do? So again, trying to coax patient preferences. If they like to, like at one time I had a patient, I said, what do you like to do? And he says, well, I used to like to listen to music. And then I asked him, I said, well, what happened? And he says, I just don't know. And so with a little bit more insight, we figured out that he was depressed for a variety of reasons. And so we actually got him into cognitive behavioral therapy, didn't prescribe him medications, and got him back to listening to his album collection. So again, just trying to get some engagement and getting people back on track for things that they like, or even looking towards new things that they might enjoy. Next slide, please.
Dr. Jervich, we have less than 10 minutes. That's a reminder. And we have a few questions also. Yeah, very good. Let's go for one more slide here. So, and actually, this is probably a good break point for our discussion. But I just wanted to add some techniques as for providers, is that you can use this technique called target practice. And you can align these little widgets with what's central, what should go into the yellow dot. So maybe being pain-free goes to that center dot. Next slide, please. So I think it's important in terms of a clinical visit, where the providers do look at prognosis and share that estimate. Because you can ask people, well, how long would you like to live? It might be a difficult question. And again, to do so in the context of what the patient wants to express. But I think importantly, as you look at the older adult, again, do they look younger or older than their chronologic age? If they look younger than the chronologic age, you want to reinforce whatever lifestyle they're doing. If they look older than the chronologic age, you might invite them to consider ways that they could reverse the aging process. And it's not far-fetched to think about that, because really it's nutrition and physical activity that are the key drivers for improving your biologic age, if you will.